Hi, welcome. I'm Ann Patridge, and I'm thrilled that you're all here with us to speak about what changes for Monday morning, this post-ASCO 2021 live discussion panel focused on breast cancer and the exciting data that were presented during the ASCO annual meeting this year. I have an illustrious panel with me here today, and I'd like to have everyone introduce themselves and to say a little bit about who they are and where they're from and what they bring to the table. Dr. Mirabeau Beale, do you want to go first?
Sure. So I'm Kristina Mirabeau Beale. I'm a board certified radiation oncologist. I practice with Genesis Care USA in Fort Myers, where I'm the clinical director of breast radiation oncology. And I'm also a co-director of our regional cancer centers, NAPBC accredited breast center, where we serve our local community and try to provide academic caliber care.
Thanks, welcome. Dr. Ademuyiwa, I knew I was going to say that imperfectly. Will you say that for me perfectly before you introduce yourself?
Good evening, and thank you for having me. My name is BC Ademuyiwa. I'm a breast medical oncologist, and I practice at Washington University School of Medicine in St. Louis.
Welcome, and thank you for correcting my poor pronunciation. Dr. Kalinsky?
I am Kevin Kalinsky. I'm a breast medical oncologist, and I'm director of the Glenn Family Breast Center at Emory University.
Thanks, Kevin. Dr. Mamounas?
I am Terry Mamounas. I'm a breast surgical oncologist, and I direct the comprehensive breast program at Orlando Health Cancer Institute in Orlando, Florida. I also chair the breast committee for the NRG Oncology.
Welcome, thank you. And we want to keep this pretty interactive, so please do enter questions in the chat. We will be taking questions. We'll talk about some of the exciting research, and we'll try and address all of your questions. And I'm going to call myself Ann. I'm going to call you guys by your first names, whether you're men or women. As you know, a year or two ago, there was some very provocative data about how we call each other. So I was trying to be really formal, but now let's keep it nice and informal as we discuss these issues, if that's okay with everybody. I think the first thing to unpack, like right off the bat, was it was really an exciting plenary for all of us because of the Olympia data. Who wants to chime in and talk about what we're thinking about Olympia in terms of moving forward and react to those pretty compelling results?
Sure, I can go ahead and start off. So just to recap, Olympia was a large phase 3 study looking at the benefit of platinum salts in the adjuvant setting in patients with residual triple negative breast cancer who had not achieved a pathologic complete response. So the randomization was to platinum salts versus observation or capecitabine. The observation arm was closed very quickly after the CREATE-X data. It was actually to olaparib versus observation. I'm mixing it up with the ECOG study.
Yeah, that's okay.
So what they found actually was that olaparib was beneficial. So patients were given olaparib for 1 year versus placebo. And again, these were patients who had germline BRCA1 or 2 mutations. They were hormone receptor positive, HER2 negative, or triple negative. And I think the triple negative population was over 82%. So the trial was positive. There was an invasive disease-free survival benefit of greater than, I think, 8%. And so this, I think, represents a new standard of care for BRCA positive patients who have residual disease, or in the adjuvant setting, high risk BRCA positive patients. But the question in my mind is, how about the patients who have germline PALB2 mutations? Will they benefit as well? These patients were not included in the study, but there is data suggesting that they also benefit from PARP inhibitors. So I'll be interested in hearing what the other members of the panel think about that.
Kevin or Terry, do one of you want to chime in about that question and your thoughts on Olympia?
Yeah, I mean, I think so. In regard to PALB2 mutations, I think it's a really important question. We have data from other series, including some data from Nadine Tung and colleagues, just demonstrating that it looks like patients in the metastatic setting can respond to PARP inhibitors, So it remains intriguing in this setting as well. Of course, in Olympia right now, we really just have data for patients with BRCA mutations. I think that we've all been awaiting these data. We saw that it was a positive study, and we didn't know the degree of magnitude of benefit that we were going to see. And to see an improvement in distant disease-free survival was really impressive and important. It's also worth noting that these patients, as you mentioned, BRCA1, BRCA2 could be triple negative, could have hormone receptor positive, HER2 negative disease, even though that was a smaller proportion of patients. But, these were quote unquote high risk. So, I think one of the questions that if patients have residual disease with triple negative breast cancer, or, lots of nodes involved with hormone receptor positive HER2 negative disease, then we have to think about, for sure, these are patients who are going to benefit from giving a PARP inhibitor. I think the question is, well, what should we be doing about other patients who are in this setting who weren't quite high risk enough? And given the benefits that we're seeing, whether or not we would extrapolate to that population as well. And I think the only other thing just that I want to mention was just this concern about the tolerability and the toxicity. And, I was looking for just rates of MDS AML. I was pleased to see that those rates were not, at this point, statistically higher. But I do think it's important for us to continue to follow that sort of data out over time.
I think that's a really, really important point. I mean, the other really exciting thing was there was a hint at a survival advantage, which they had very stringent rules about that. So we're not allowed to say that it did yet, nor the statisticians, but that was pretty exciting. I want to ask what people think about the timing of the, assuming that olaparib gets FDA approved in this space. What are we thinking about for very high risk ER positive patients? If, for example, the CDK4/6 inhibitors, abemaciclib gets improved in this space, how are you going to manage that? I mean, I know that's not a Monday morning question, but are you going to choose one or the other, or try and sequence them in a BRCA carrier who's high risk and ER positive, multi-node positive, and presumably fit the Monarch studies?
Yeah.
I think that's a great question, and I guess we'll have to cross that bridge when we get to it. But I think for now, obviously, you give them a PARP inhibitor or olaparib, and if approval of the CDK inhibitors, I guess you have to look for safety data with a combination, and then whether it will work when you give it together. Obviously, it worked giving it together with endocrine therapy for ER positives, so maybe you take the leap of faith. But tolerability, and again, I'm not sure, maybe you guys know of data of safety with a combination, but obviously that data needs to exist before you can even entertain using it. If else, you may use it in sequence, but then, of course, you give the CDK inhibitor later on that was given in the monarchy.
Yeah, we talked about that a fair bit at our tumor board already, just because, the high risk people are coming along and we're saying, okay, it's not approved yet, but could we get away with giving it? And yeah, no one's aware of any combination data and the safety of that. And I'd be really worried about blood counts.
Yeah, the overlapping toxicity with the blood counts is what I was thinking about as well.
Yeah. Yeah, as far as the sort of level of risk and whether you can go outside of the sort of the criteria that we use in this study, I guess you can sort of do the math in your head and apply this 40% reduction. And, if the risk is a little bit lower, I mean, you can sort of expect an absolute benefit that may be a little bit lower for that category. But that's why I think a hazard ratio is a more important thing versus sort of the absolute benefit in these studies, because you at least get an idea of the biologic effect of treatment, and then you apply it in different populations.
Yeah, I mean, I think that it's getting complicated, and the studies are designed about when it's a moment in time, but then the field changes, right? So I think for the CDK4/6 inhibition question, I think we're still waiting to see over time whether those curves kind of come closer together, similar to what we saw in Penelope B. So to answer your question, I think if we lived in a world where both were approved, then I would probably start with a PARP inhibitor, and then depending upon how things are going, take it from there. I think the other question is, in the triple negative setting, what about if they have residual disease We give them capecitabine. And, what about if we're in a world where we're using checkpoint inhibition? Because there's certainly some data about combination of PARP inhibitors with checkpoint inhibitors that are some compelling data. But, of course, that's not how the study was designed. And I think this is going to be a moving target.
Yeah, really important points. Kristina, I just want to ask you, as one of the local therapists on the panel, a radiation oncologist, what does this mean in terms of, say it gets approved and people are starting to take it? What are you thinking about sequencing in terms of, can they start it before they get their radiation if they're getting radiation? Do we have concerns about that? And what's the state of that?
Well, I think, we think of the PARP inhibitors as a class as having a radiosensitizing effect. And there are a lot of data, kind of phase 2 and then other even disease sets looking at the interaction of concurrent radiation, with different PARP inhibitors. I would be worried more about the side effect profile, especially with concurrent therapy. A lot of these patients, with metastatic disease, we're treating to hopefully, relieve their side effects or improve their quality of life. So I think interactions like that have to be considered. And then especially as we have more patients, with like oligometastatic disease, with kind of the Saber comment data, bringing radiation therapy, more to the table in terms of patients with stable metastatic disease. I think a lot of these interactions just have to be explored, and I'd be worried about the side effects.
So for now, assuming it gets approved, wouldn't do it at the same time without some good safety data that come out, or some other reason to do it. And I'm sure in Olympia, I don't remember offhand that they sequenced it like that.
I believe it was, I'm pretty sure it was sequenced because I think you have to kind of indulge the treatment before you get randomized. So I think it's sequential.
Thank you. And before we leave the Olympia study, there was a question that was posed by an audience member prior to the program, which was, can olaparib be used for older patients with BRCA1 or 2 positive breast cancer who are not candidates for chemotherapy? So that's interesting. So giving it without all of the other, either neoadjuvant or adjuvant, or someone who just says, I don't want the chemo, but I'll take the adjuvant targeted therapy, whether they're ER positive or ER negative.
I don't see why not. I mean, these patients weren't represented in the study, but on the other hand, it was monotherapy anyway. So, I mean, you can take a leap of faith. Certainly won't be much of a toxicity issue, more so than the study had. So I think that would.
There was some intriguing data that Jennifer Linton and the individuals from MD Anderson have presented just in terms of neoadjuvant talazoparib, and they saw a nice rate of pathologic response. They did have patients who did not respond and had some progression, but those are some supporting data. I would say that it's not really standard of care, but those are some intriguing data that were presented at ASCO.
Right, and lots of efforts looking into now trying to maybe de-escalate in some settings for people who have a nice response. There's a question from the audience about, and this gets back to the ECOG data that the BC was starting to tell us about, so we'll do that next, which is, are there any data on PARP inhibitor and capecitabine at the same time?
So the trial, which I jumped ahead and was talking about, was actually comparing platinum salts to capecitabine in patients who had residual disease with triple negative breast cancer. And, it showed that platinum salts were not superior to capecitabine and were actually a little bit more toxic. So capecitabine does remain the standard of care for these patients who have residual disease with triple negative breast cancer. I think the question that, came up with the Olympia study was, if you have a patient with triple negative breast cancer that has a BRCA mutation, which one will you choose? Would you choose a PARP inhibitor adjuvantly, or would you choose capecitabine? And there was a discussion about the metastatic trial, so Olympia with a D, and that compared olaparib to treatment of physician's choice, and I think about 50% of the patients got capecitabine, and olaparib was better. So one would think that olaparib would be the choice rather than capecitabine in these patients with triple negative breast cancer who have a BRCA mutation. But in general, for capecitabine, remains the standard of care versus a platinum salt for the general germline patients who don't have a germline mutation.
Thanks, BC. And I think the interesting thing about the Olympiad data and the corresponding data with talazoparib is that both studies, when compared to physician's choice, again, many of them would have been capecitabine in the metastatic setting for mutation carriers. Both of them also showed pretty impressive differences with regard to deterioration of quality of life. So not only, that's the way they measure in the metastatic setting, which is not only is it better to treat the disease, but there is a less of a slower pace of deterioration of quality of life in the groups that got randomized to the PARP inhibitor. Obviously, that's a different setting than in the adjuvant setting, but if someone's worried about toxicities, generally, the thing that works better helps better, and the thing that, the PARP inhibitor seems to be a bit better. So that's exciting data. Any other comments on E1131?
I mean, to me, it was really, it really just highlighted the unmet need in patients with residual disease, right? If you look at that 3-year invasive disease-free survival with capecitabine, right? Like, I think it was like 3 years was like 49%, right? Like we just, this is a real opportunity for us to do better. And I know that there are discussions about other sorts of evaluations in this setting of residual disease with triple negative breast cancer, but we have work to do.
The other thing about the study, the way I think about it, and again, some people may disagree with that, but I mean, the platinum salts are starting to move a little bit in the earlier setting in triple negative breast cancer, in the neoadjuvant setting. We have some data, and we'll hear more data. I mean, the brightness data, I think, will be presented later in the year. So for those who adopt platinum in the neoadjuvant setting, then obviously capecitabine is the only and best option afterwards if there is residual disease. So from that standpoint, I think you don't lose much if you potentially use platinum up front and then don't worry about, post-neoadjuvant, then you use capecitabine, of course.
Right. So hopefully we'll hear some exciting data in the neoadjuvant space with IO and checkpoint inhibitors that will have fewer and fewer people with residual disease who need things out back. Great. Any other comments on 1131? I think unfortunately it wasn't practice changing, but it's so important to be doing these trials and doing them as part of the cooperative groups who are, one of the few areas where you can do these trials to really test kind of the old guard drugs against each other. All right, let's switch gears, and we got a little bit into the neoadjuvant space. There were some interesting data presented, particularly by the West German group, Nadia Harbeck, in the ADAPT studies. And I always have a hard time kind of teasing out all of the permutations of ADAPT, but I want the group to focus a little bit on the data where they looked at the ER negative set and patients were treated with anti-HER2 therapy preoperatively. Does anybody want to comment on the findings and kind of, should we do anything differently in our clinics because of that? I want to start. Kevin, you want to take this one on?
Sure. I also, with the West German group, it always takes me just a moment and then a reconsideration to get to the details of what could be practice changing. I think ultimately so in this study, patients were randomized to get, Taxol, Herceptin, Perjeta, or, getting monoclonal antibodies without a taxane. And we saw that the PCR rate was higher if you got a taxane. And I think the take home to me was that, you had a nice PCR rate of, I think it was like a little less than 60% if you had Taxol, Herceptin, Perjeta. And, this bodes well for potentially for other studies that are ongoing, including the COMPASS studies, right, which is looking at giving taxane, Herceptin, Perjeta, I believe, for 4 cycles to see, we get so much bang for our buck with giving the monoclonal antibodies. And it does seem like giving some chemotherapy right now does have some additive benefit for achieving PCR, but potentially we can decrease the amount of therapy that we may need to give in order to achieve a PCR.
Yeah, and they had pretty astronomical rates of PCR.
Right.
They were all hormone receptor negative, so you have to take it a little bit in that context, but they were more in the like 70 plus to 90s range. It was very exciting, depending on how you define PCR, which is really nice, and I think speaks to, from where I sit, it speaks to the excitement around the crescendo and decrescendo, the decrescendo trial in Europe and the Compass PCR trial in the United States about trying, is PCR good enough in the HER2 positive setting, and can we not give the rest of the chemotherapy after you give a THP type regimen and the disease melts away?
Yeah, one of my concerns was that I think the monoclonal antibody arm alone seemed to have somewhat worse outcomes, though.
Yep.
And there were a small number of patients, so it's very hard to be definitive, but it certainly trailed the other group. Now, I think what they showed, if I read that correctly, is that if they had a PCR, then the outcome was pretty good, and it was as good as the chemo, which I think speaks well for de-escalation strategies. However, somehow you have to sort of demonstrate that you don't lose much by giving less effective therapy up front, hoping for PCR, because for the non-PCR patients, it's very hard to know what will happen to those, and apparently they don't do that well. Obviously, some of these studies give the therapy out back, either anthracyclines or additional therapy, and obviously there's also TDM1 for that setting. But that was one of my concerns, that I saw that it was a little bit worse.
Yeah, there was presumably you could give people things out back if they didn't have a PCR, and I'm looking at the slides right now, so there was actually a delta in the disease-free survival by arm. So it's maybe that you can't make up for it if they didn't have a PCR in quite a timely way. So that's a little bit, gives you pause to do you really want to move away from the chemo that quickly in patients, especially someone who's higher risk?
Yeah. I couldn't help but think about I think it was the NHP study, right, where patients got either concurrent taxane, Herceptin, or it was given sequentially, and then if given concurrently, patients better.
That was the NCC.
The NCTG trial.
But so, that where the patients did, but it seems like there's this additive effect of giving the taxane with the HER2 antibody. I couldn't help but think of those data when looking at this.
The other thing I think was interesting is they presented some biomarkers data suggesting patients who might not necessarily be good candidates for the antibody therapy alone. So they looked, and the patients who had a basal status had, I think, no PCR. And then patients who didn't respond initially on their initial biopsy, I think they looked at Ki-67 as well as TILs. So those patients didn't have any good responses to the dual chemo-free arm. And then patients who are HER2, I think 1+ or 2+ who are FISH positive, also didn't seem to have a good benefit from the chemo-free arm alone. So I think all these are intriguing, not practice changing now, but maybe for the future when we're de-escalating and selecting patients for less intense therapy.
No, that's a very good point. So I won't say never can we leave out the chemotherapy. It's just not right now. Or not at least without something. Maybe we'll get smarter and it'll be a different targeted agent. Okay, other comments on that?
My only additional comment is just, that somewhat recapitulates the Neosphere data, right? Because there was that one arm where patients just got HP and they saw a PCR rate that was like less than 20%, but there were some patients who'd achieved a PCR. So, and I think your comment of like, if we can get smarter and better predict who those patients are, there are some that their tumors are just exquisitely sensitive to the HER2 monoclonal antibodies.
No, I agree. All right, good. Let's now move into the sub-studies correlative space, as BC took us there. And there was some nice provocative data from B42, for example. And maybe Terry, you can kick us off here, given that's your group from a cooperative group standpoint. Tell us about the analysis looking at the BCI in particular, and what do we take home from that?
So we evaluated, so in B42, as you know, it was a trial of patients with ER positive, HER2 negative, ER positive actually was also HER2 positive, but didn't care much about that, but it was ER positive breast cancer that was disease-free after 5 years of endocrine therapy with either an AI for 5 years or with tamoxifen followed by an AI, the sequence of which total 5 years, and randomized patients to letrozole for 5 years or placebo. And we did show a significant improvement in disease-free survival with the updated data of 10 years. The absolute benefits were small, about 4%, and obviously there was no survival difference, but there was reduction in distant, significant reduction in distant recurrence and breast cancer-free interval events. So with that in mind and having small absolute benefits, you know, we sought to evaluate ways of identifying patients that do better with endocrine therapy with higher benefit or less benefit. So trying to optimize the patient selection. And so we looked at several genomic classified, commercially available genomic classifiers, and we presented in this meeting 2 of them. So BCI was one, and particularly the BCI H/I ratio, which is the homeobox 13 interleukin 17 B receptor ratio component of the BCI test. And this test, as you know, previously has shown that it can predict benefit from extended endocrine therapy in different settings, both with extended tamoxifen in the Transatom trial, and with extended AI after tamoxifen in the MA17 trial, and also in the IDEAL trial, one of the Dutch trials that looked at 2 different durations of extended letrozole therapy. So there was a significant interaction in these studies in favor of benefit for BCI H/I high patients versus BCI H/I low patients where we didn't see significant benefit. So along those lines, we evaluated this in B42 in about, starting with about 2,300 patients, but the final sample size was about 1,800 or so patients after excluding some that didn't have enough tissue and could not get an appropriate test. So the primary endpoint was relapse-free interval, looking at the effect of extended letrozole therapy according to the BCI, H/I high or low groups. And to make long story short, the primary endpoint was not met. In other words, there was no significant interaction on the effect of letrozole with BCI H/I high or BCI H/I low. Interestingly, when we looked at some of the other endpoints, again, there was no interaction, but it appeared that, for example, for breast cancer-free interval and disease-free survival, which are endpoints that include also contralateral breast cancer, the H/I low patients appear to have more benefit, although there was no significant interaction. And that could be explained with an imbalance in the contralateral breast cancer. So aside of the recurrences, for whatever reason, in B42, we had a little bit more proportionally more contralateral breast cancer. That explained that finding. But another finding from the study was that, you know, when we looked at the distant recurrence in B42, there was a significant reduction in favor of letrozole, but the difference started after 4 years of follow-up almost. There was a non-proportionality in the hazard rates, with significant non-proportionality. So based on that and the fact that there was also non-proportionality in the hazard rates for the H/I high patients, we did what we call conditional analysis, which are exploratory analysis, but they're conditional analysis where we condition to the first 4 years and then look at the benefit the first 4 years and the benefit from year 4 to year 10. And again, to make a long story short, it appears that the H/I high patients benefited more from year 4 to year 10. When it came to distant recurrence, the H/I patients did not seem to benefit in that conditional analysis. And we looked at this according to other factors such as nodal status, and most of the benefit was in node positive patients, again from year 4 to year 10, and also according to prior tamoxifen or not, in other words, 5 years of AI or prior tamoxifen. Again, the benefit appeared to be in the prior tamoxifen patients with a BCI H/I high after 4 years. And lastly, none of these interactions, of course, were statistically significant because maybe the study wasn't powered adequately because of the sample size that we have available for us. Finally, there was an analysis according to HER2 status, and it turns out that for HER2 negative patients, there was actually a significant interaction. In other words, patients benefited if they were H/I high and from year 4 to year 10. So that group actually showed the statistically significant difference. So the conclusion was that we didn't meet the primary endpoint, which was to show that the relapse-free interval, letrozole effect is different in patients with H over I high versus low. But there were some suggestions that with a conditional analysis, patients with H over I high benefit more from extended letrozole versus the H over I low. And actually, the way we look at the curves, it may be that we have to follow these patients even longer before we can see even the benefit of treatment. This was the pattern that we've seen previously in the Transatom trial and the IDEAL trial. But again, this is what we found now. At this point, again, taking the data in totality, you see the 3 other studies have shown this interaction. We didn't. Sometimes not every study will show the same things. So I won't necessarily change my practice at this point relative to BCI. But again, these data are out there, and obviously we'll have an ability to publish it.
Terry, I forgot why you should have an encyclopedic knowledge of that particular presentation. So I forgot that you had presented it. So thank you. So can you share with us what is your practice, given it didn't change with your analysis?
I think, I don't see many of these patients anymore because our oncology sees them, but most of them still order BCI as a means of predicting who may benefit from extended endocrine therapy, extended aromatase inhibitor therapy. Let's not forget also that, when you look at an overview analysis of extended letrozole, extended IAI therapy, the benefit from extended AI therapy is much less versus when tamoxifen is followed by an AI, or tamoxifen followed by an AI is followed by more of an AI. So clearly, AI followed by AI is a setting where we don't see a lot of benefit in general, and there's definitely no survival benefit in any of these studies that we've seen so far. So yeah, I mean, selectively, I think I would still use BCI. And again, you can dismiss the previous 3 studies that show this benefit apropos of B42 only. So,
in terms of the prognostic and predictive value, what about you, BC? Do you use it?
I do use it. I tend to use it in more intermediate risk patients. For patients who are higher risk, multiple nodes involved, I tend to recommend they consider going longer than 5 years. If they're struggling, then we get the BCI. For patients who are very, very low risk, node negative, older women, strongly ERPR positive, I don't necessarily get it as for most of them, but for all those patients in between, that's where I find myself using it most.
That's a good.
If I may add, and if I may add that we did not present a lot of prognostic information in this presentation, but we still have as a secondary endpoint to look at the BCI prognostic part of the test. So eventually, we hope that once we analyze the data fully, we may be able to create models where you incorporate prognosis, both with the genomic tumor size, nodal status, and relative benefit from extended endocrine therapy, and be able to construct a nomogram that can help people decide how much risk do they have and how much benefit would they expect.
Yeah, and congratulations for capitalizing on that great study and the ability to at least start that process. Kevin, do you want to comment?
Yeah, I mean, I think, first of all, I think that that's a great idea, right? To model it the way that we are doing with RS-Clin, for instance. I think that that would be extraordinarily helpful. And I have a similar approach to BC, just in terms of I don't talk about it with everybody, but sometimes it's helpful just to have an objective measure to determine whether one, the potential benefit for continuing. And I do think, Terry, in your last slides that you had, to me, what stood out was just, as you'd mentioned, the kinds of events that you were seeing and the percentage of local events that you were seeing, and compared to some of the other studies. So I do wonder, as you'd mentioned, just in terms of additional follow-up, there are additional kind of distant events, whether some of those data could potentially change. But I think that they have data, prospective, retrospective data in node negative and node positive disease, really N1 disease. So I still think that keeping all of that in context when making that decision is important.
Right. And that's why we used RF5 for that study as a primary endpoint, which is the relapse-free interval, which includes only recurrences. So we excluded the contralateral breast cancer, but yet that decreased the power to detect potential differences because you only have so many events. So if I may, if there's no other questions, I can also mention the second study that we did and presented. Priya Rastogi presented the evaluation of MammaPrint in this same cohort of patients. So this was a second correlative study from B42, looking at MammaPrint as a same way predicting benefit from extended endocrine therapy. Now, we didn't have a lot of prior data with MammaPrint as a predictor of extended endocrine therapy, but there are some data with the MammaPrint ultra low to look at patients that do very well and perhaps may not need much extended endocrine therapy. So for that study, the primary endpoint was distant recurrence. And again, looking for the effect of letrozole on distant recurrence with MammaPrint high versus MammaPrint low. That was the primary endpoint. Now, I won't necessarily get into what the hypothesis was, whether MammaPrint high would be the one that benefits versus MammaPrint low, because I don't think we had a clue either way. But it turned out that actually MammaPrint, although again, the primary endpoint interaction was not significant, but it was evidence that MammaPrint high patients did not benefit from extended endocrine therapy, but it was MammaPrint low patients that received the extended letrozole therapy benefit. And so,
which was very curious to a lot of us, right?
Curious, and trying to explain, it's hard to be definitive about it, but you may think that maybe MammaPrint high patients are less endocrine sensitive. They get most of the recurrences the first 5 years, and those that remain after 5 years, maybe they're not that, endocrine sensitive, versus the MammaPrint low, that may be more the endocrine sensitive patients. Again, hypothesis generated at this point because this is the first time we saw such data. And then, although let
me just interrupt you. I think the other thing you have to remember is, because we also saw other data suggesting that we might even want to de-escalate in MammaPrint low patients at ASCO and not even give them endocrine therapy. And we're thinking about that, not that that's ready for prime time, but you have to consider the person who would even be considered to go into an extended endocrine therapy study, right? And anatomically, those people would always have more disease on average, right?
Right. And yeah, part of it was, well, I will mention a little bit in a minute, is that because there was also this MammaPrint ultra low analysis, a sub-analysis of the low that we did as a secondary endpoint. But to say that the distant recurrence was not, the interaction was not statistically significant, but there was statistically significant interactions for disease-free survival and breast cancer-free interval in favor of MammaPrint low being the group that benefits. And then we did a sub-analysis of MammaPrint ultra low, versus, which is a very good prognosis group, versus the low but not ultra low. And in there, we did not see again an interaction of benefit, but it appears that the majority of the benefit comes from the low but not ultra low. The ultra low, you couldn't exclude that they get benefit, but it was less. So that's sort of the main findings from that study.
That's more consistent than with, yeah, that's
right.
easy.
So you have some risk, but then you're not as low where you don't need to do anything then. So from this, so this was essentially, despite the fact that the primary endpoint was not, interaction was not statistically significant, but we saw evidence that there was a differential benefit. But again, one of our conclusions was that, obviously we like to see this data replicated in other data sets, because it's the first time we see with MammaPrint that there is this extended therapy. And again, also we will evaluate it prognostically in subsequent analysis as well.
Other comments on that? Kristina, any thoughts on late recurrence, local, regionally, and any new data in that arena?
Well, even a question I actually wanted to ask is if you find that adherence is any stronger to this extended endocrine therapy in year 4 and beyond, because even just in our practice, getting patients through that initial first few years is often challenging. And even though it's not exactly kosher to, offer a patient, endocrine therapy versus, like a short course of radiation, often patients say, well, can I do one versus the other? Mostly just because of the side effects and inability to really tolerate some of the patient, some of the quality of life aspects of being on extended endocrine therapy, or even initial endocrine therapy, I should say.
Yes, the only thing I can say is that in B42, we looked at the adherence to protocol therapy, and it was about 60%. So we lost about 40% of the patients by the time they got to the 5 years. But interestingly, it was very similar between the placebo and the letrozole. So just tired. People just want to take pills
apart after 5 years.
They show that in the DCIS setting too, or prevention, but more people come off actually, even in clinical trials. So that's interesting.
There was a clinical trial that was presented a couple of years ago. I can't remember the name now. And in this clinical trial, patients had already completed close to 5 years of endocrine therapy, and then they were getting extended, but they interrupted it sort of consistently. I think they gave them every 3 months. Sorry?
The Soleil trial.
Yes, yes. And that was the only trial that I've seen that interrupted endocrine therapy. And apparently there wasn't any worse outcomes in those patients who took, some break. So that's a strategy that I've, used in patients who are having a lot of toxicities and need to go on extended endocrine therapy. Some breaks here and there doesn't necessarily hurt patients. So.
Yeah, I mean, they give them about a 3-month holiday every year, and didn't see any difference.
I mean, the only thing that I would add to it was nice to see performance of MammaPrint in this sort of setting. There have been other studies, like from the TransATAC study, where they compare different genomic platforms, and the 70 gene assay was not one of those. So it was just good to see kind of its performance in a prospective retrospective study.
Very well done. All right, I'm gonna shift gears a little bit, but we're gonna allude to that the space of metastatic hormone sensitive, or at least hormone receptor positive breast cancer, because there were a fair number of updates on CDK4/6 inhibition in the metastatic setting. Does anybody want to start us off talking about either Paloma 3 or the Mona Lisa 7 or 3 was presented, I think, the updates? Anybody interested in? Kevin, you look ready.
Sure, I'm happy to do it. So, we saw overall survival updates for Paloma 3, which again was giving fulvestrant plus or minus palbociclib. And that was really not those were not really like in the frontline setting. And then we also got overall survival data from Mona Lisa 3, which was fulvestrant plus or minus ribociclib, and included some patients in the frontline setting as well as in the second line setting. So when interpreting these data, it's always important to think, okay, what were the populations? Do they have prior chemo? Things like this. And ultimately, we see an overall survival advantage in particular in Paloma 3, it was the patients who had not received prior chemotherapy. It was 2/3 of the patients did not receive prior chemotherapy, and they had an overall survival advantage. And I believe that advantage was about 10 months or so. And then in Mona Lisa 3, we also saw an overall survival advantage for about 10 months or so. If you look at landmark analyses, like for instance, at the 5-year point, there was about about a 15% difference in terms of survival. And I think, there's just some consistency to these data, just the fact that we're seeing this overall survival advantage across various studies. We've seen overall survival data in the Monarch 3, the frontline study. But it's nice to see. I mean, there's still some studies that we're still waiting for some overall survival data, like Paloma 2, the frontline AI plus or minus palbociclib study. But this, I think, just further sets that these are standard of care options. I think there may be some providers who have been awaiting overall survival data, which, for this particular subtype of breast cancer is not always the easiest to achieve. And we've achieved this in multiple studies. So this is clearly standard of care for our patients with metastatic hormone receptor positive HER2 negative disease.
Yeah, I think each of them has shown an overall survival benefit in at least one study to date now. And so I would push back and challenge each of you to think about this. So should we change anything? I tend to, and I don't know about you guys, but I'll be honest with you, I tend to have kind of a Coke and Pepsi approach. And when I'm talking about which endocrine, not which endocrine, but which CDK4/6 inhibitor to reach for, and I base it on, side effects, tolerability, whether the patient is going to be good at taking a 21-day on and 7 days off kind of regimen, and count issues and things like that. And whether they want to come in and get EKGs and the like. And so I'm not sure what everybody else does, but did anything that you heard at ASCO 2021 make you lean towards one or the other more so?
No, I take the same approach as you do. I think they're all very, very good medications. And again, it's really, for me, it really boils down to the tolerability and, what patients are willing to put up with if they want to come for, extra testing. I think with COVID now, some companies are able to do testing at home. And then the side effect profile with, some of them, the GI toxicity, some patients don't want to, put up with that. And other patients are concerned about their counts. But I think overall, it's nice that we have lots and lots of options and they all work overall, quite well.
Terry, you want to chime in? What's your?
No,
I
I mean,
realize we're not prescribing these all the time, but you have.
prescribe those, but I think looking at the data, I think all are great drugs and appear to be very similar, although obviously with Ameba, the toxicity is a little different than the other two, more the GI, less the hematologic. But, and obviously in the adjuvant setting, you'd see the difference between the, Pallas and Penelope and Monarchy. But, we've been there before with AIs and other drugs. And at the end of the day, I don't know. It may be a different situation here. I was interested in looking at one of the other studies that was presented, the Chinese trial with Dalpacil-clip, something mispronounced, and showed the same kind of benefit, right, in terms of progression-free survival. So maybe there's more drugs in that setting, but they all appear to have, to me at least in the metastatic setting, similar effects.
And does anybody make anything of, I've heard this brought up by people before, the studies that have shown the biggest survival advantage have been those that combined the CDK4/6 with fulvestrant, as opposed to the ones there are some data with AI, notably MONALEESA 7, which is a premenopausal study, does show an overall advantage. But most of the ones that have shown the biggest bang for the buck in terms of survival are the ones that have been combined with fulvestrant. Does anybody make anything of that? And does it make you want to reach for fulvestrant instead of an AI as first line, recognizing that's less, unless they obviously are coming off an AI and recurred on it? Any thoughts on that, Kevin?
I'm
not sure. I'm just throwing it out there.
I can't remember the name of the study and it's driving me crazy. So one, I just want to say Monarch 2 showed an overall survival advantage. I want to be specific. I want to be reliable.
That was with fulvestrant, I'm sure.
Fulvestrant. So there was one study, oh my gosh, it's not called Polaris. There was a study, a randomized phase 2 that looked at an AI plus CDK4/6 versus fulvestrant plus CDK4/6, and there was no difference. So, based upon that, I still think that I tend to use the data from, okay, if a patient has progressed on an AI within 12 months, then I use fulvestrant. Otherwise, I still use an AI. I think we'll get some additional data with the oral SERDs, right? So there are studies that are opening that are comparing an AI plus CDK4/6 inhibitor versus oral SERD plus CDK4/6 inhibitor. So I think the story will continue. And, the other thing, just to go back to the last conversation we were having, the only time that I really think about preferentially using one specific CDK4/6 inhibitor is in the premenopausal group, based upon MONALEESA 7. And it's hard for me now, just in the absence of having the Paloma 2 data, where we see an overall survival advantage in premenopausal women. I will say in that subgroup, I do tend to use ribociclib just because we have data for that. I'm not so sure that there's a difference. It's probably a Pepsi Coke thing, even though Pepsi, I have to say this, being an Emory, Coke is, which is really funded by Woodruff's and the Coke. Coke is clearly better. But in that setting, I do use ribociclib.
Okay. Other thoughts, BC?
Funny enough, the premenopausal patients who I'm thinking of CDK4/6 inhibitor, I would say about 75% of them come asking for ribociclib. So, and since, I don't think that there is a real big difference between that and the other CDK4/6 inhibitors, I'm happy to prescribe that to them. But other than that, again, I think it's kind of a Pepsi and Coke situation. But I've had a fair number of them ask specifically for that medication.
Yeah. As a person who focuses on breast cancer in young women and unfortunately sees a fair number of these patients, I do treat it as a Coke and Pepsi approach. but I'm not sure if I'm right, Kevin. And I do appreciate and very much appreciate that the Mona Lisa 7 was one of the first studies that other than Paloma 2 that did proactively include premenopausal women without making them go get their ovaries out, because early on that was a challenge to caring for these patients. All right, this has been a really good discussion. We have about not even 10 minutes left. Please send in your questions because we're happy to address them. And I want to get at a couple of other abstracts that were brought up. One of the ones I wanted to bring up, which I think is just a really interesting one, was the one that was presented by, I think she was a patient advocate around, and I think this is really interesting data around how patients felt about treatment-related side effects and views about dosage assessment to sustain quality of life. I don't know if, Kristina, if you wanted to start and comment on that, because it's relevant for everybody's specialty in everybody's area. You know, do you dose the radiation differently for quality of life, and especially in the metastatic setting? I think you guys do, right?
We try to, yes, or we should. I think big picture, what I found really exciting about those data is the fact that, you know, patients seem to have a lot more flexibility than probably we give them credit for, especially in terms of being willing to adjust or consider altered doses, especially, you know, most patients I think identified as having had side effects, or 20% had even had a hospitalization potentially. And so in terms of adjusting the dose, patients seem to really want flexibility and consideration from their doctors in terms of altering their dose. I think we need probably similar research in the radiation sphere. You know, for a lot of these patients who have metastatic disease, you know, we try to really do hypofractionation whenever possible. And then obviously kind of bringing up even some of these class effects, as you were mentioning, with kind of the CDK4/6 discussion, you know, even in terms of kind of subtle differences in side effects in terms of the overlap with radiation also become important as well.
And BC, did you go home on Monday after that presentation and start asking their patients if they wanted a dose reduction for their metastatic treatments?
You know, I think it's something that we really do need to think a little bit more about as a community. You know, particularly for patients who have advanced disease, they're going to stay on treatment essentially for the rest of their lives. We need to pay more close attention to their quality of life and be more apt to reduce and modify doses so that patients can stay on therapy and, you know, enjoy their lives. So it was, I mean, it's something we think about, but I think we need to think about it a little bit more frequently and ask patients, you know, how they're doing and if they're happy with their quality of lives and things like that. So, you know, it kind of reinforced what we're doing, but what we need to do more, so.
And there are data relevant to our just prior conversation about the CDK4/6 inhibitors. There are data, at least I know for Palvo, and they probably exist for the other two main ones in the class, that as long as the doses get reduced for effective toxicities, and not just because people feel like it, that efficacy is maintained. Which is very reassuring. I don't know of the data with the other two, but that's my understanding.
Yeah. You know, sometimes it's very interesting how patients just light up when you propose a dose reduction or, you know, a treatment holiday for even just a few weeks. And, you know, they've been thinking about this and they don't necessarily tell us because they're worried about reduced efficacy or you taking away their, you know, treatment. But when you propose it and say it's going to be okay, it really does, you know, change. It really does give them some, I guess, extra hope and improve their quality of life. Yeah.
Kevin, do you want to comment on that and how you might manage that? I mean, I think it's a really tough, actually, thing to talk about with patients and introduce, especially if you're worried about their response to full dose. You know, I think that it's, once you've had someone on disease and treatment for a while, we start thinking about that. But Kevin, do you want to comment?
Yeah, I mean, it's complicated. And, you know, there was a questionnaire that was also sent out. So one, I mean, this was a huge effort for the patient advocacy community to do this. It was like greater than 1,000 patients responded to it. And there was also a medical oncologist survey with somewhat similar questions that was sent out. And, I'm curious to see the results of those data. I also had just kind of the reaction of, patients, the rate at which patients described having bad toxicity that led them to go to the ER, was higher than what I would have thought it would be. And then the other thing is, subsequent to this presentation, the FDA, had an announcement just in terms of, thinking about how we're optimally determining doses based upon early phase studies. So I think the jury, we'll see whether or not this impacts ultimately how we think about dosing in patients. And also the name of that study, by the way, that we were talking about before is called the Parsifal study. So I just wanted to circle back to that.
I was trying to look it up between your comments. Please do send in your questions. I'm reminded that we actually have another half hour to talk about the exciting data. I jumped the gun, and I hope I'm not standing between anybody and their dinner. If you're in the East Coast, at least, as we near that hour. What else did we see at ASCO that's exciting and that made us think twice in the clinics that next week? I'll tell you something that interested me, and it was I think it was a Chinese study that looked at the use of, I believe it was endocrine. Yes, it was a Chinese study in the oral session that looked at the use of endocrine therapy with anti-HER2 therapy. And I'd have to look up all the details, but they actually had pretty decent response rates and control for a reasonable proportion of the patients. I didn't know if others caught that one or what you all thought about it. And the reason I thought about it this week is because I actually have a patient who came to me now. Well, she was 21 when she came to me. So, an undergrad. And she had been one of these people with a lump that somebody had watched until she got back pain. I mean, a horrible story. And she's still with me now, and it's about 9 or 10 years later. So 10 years later, because she's 31 now. And she, when I first met her, her biggest concern, relevant to what we were just talking about, was we had to radiate her spine because she was in pain. And then we had this HER2 positive mass and only one area of oligometastatic disease. Her biggest thing was she didn't want her hair falling out, and she had locally not treatable disease. It was so locally advanced. It was treatable but not curable. And so we kind of negotiated, and at that time I treated her actually initially only with hormonal therapy because she didn't want anything IV. And then when she eventually had a progression 3 or 4 years later, I treated her with anti-HER2 therapy and endocrine therapy. I don't remember which second line it was. I think it was, it was AI or TAM. And it was fascinating that I think I got about 6 years out of giving her endocrine therapy alone and endocrine therapy with anti-HER2 therapy until I actually had to reach for, at that time, I think the next one I had to reach for was TDM1. Because she didn't want her hair to fall out still, and THP wasn't an option at that point. And we weren't doing cooling caps. Thoughts on treating some patients with endocrine therapy and a HER2 directed therapy in the metastatic setting or in the early setting?
Well, I mean, I don't know. For me, when I looked at that study, a couple of things jump out. First of all, they use Herceptin only in the as a one antibody. There was no pertuzumab used. And the second was that the outcomes on, I think, was first-line therapy, if I'm not mistaken, or included first-line patients, and it wasn't nowhere near that you would expect with like Cleopatra.
Yeah.
So, but you're right. The two arms were very similar, in outcomes, and chemotherapy, of course, was at the choice of about multiple different chemotherapies. So I'm not sure if that will change our practice or your practice where you guys treat in the metastatic setting.
And everybody presumably, tell me, is using THP in the first line metastatic outside of a trial? Yes?
For most patients, I mean, there's some patients that you think may not be chemotherapy candidates and have ER positive, HER2 positive disease. And, you know, for those patients, I would use endocrine therapy with dual anti-HER2 blockade. But, you know, for most patients, I would typically use a taxane, Herceptin, Perjeta, and then stop the taxane after a certain number of cycles, and then introduce endocrine therapy to continue maintaining them on dual anti-HER2 blockade. But I think this trial is reasonable for patients who may not be chemotherapy candidates. And presumably they might have a higher response or longer PFS if you add in pertuzumab.
Cool. Other comments on that?
Yeah, I've had a patient situation that was very similar to what you were describing, where I had a patient who just refused to get chemotherapy, and we did hormonal therapy and HER2 targeted therapy, and she's been on for a long time. So I think it does continue to ask the question about de-escalation. What do we really need to do? Because even from the Cleopatra data, there's some good percentage of patients who are on frontline therapy for a long time. So it did give some additional support for that.
Thank you. And there's a question from the audience that's asking, and this was a great study, so forgive me for not getting to it yet. Do you think the durvalumab neoadjuvant study was convincing in its progression-free survival endpoint? And does someone want to review the findings from the Durva? That was the GBG neoadjuvant study. Anybody remember the details?
Yeah, I'm happy to do that. So in the study, patients received, there were some patients who received a window of getting Durva, but patients essentially got Durva, so got taxane anthracycline-based therapy with or without Durva. And, there was no improvement in PCR, even though the initial question was those patients who got a window, like whether they were benefiting. But I think what was interesting is that they were seeing an improvement in long progression-free survival, distant disease-free survival, and a hazard ratio of like around 0.2 for overall survival, albeit that was a pretty broad confidence interval that was reported. I mean, I think to me this was not in itself practice changing, but it does ask the question, it asks a few questions. One, like whether PCR is really going to be the best surrogate for long-term improvement with giving a checkpoint inhibitor. Of course, for KEYNOTE-522, we've seen an improvement in pathologic complete response. And we know now by press release that event-free survival, that difference is now statistically significant. But it does ask that question of the importance of PCR in this context with that particular class of agents.
Yeah, I was really struck because she presented, Sybil Loibel presented that 3 years ago at ASCO in a special oral session. And it was striking that it was negative in terms of PCR, but that window of people who got primed with a little Durva before their chemo, there did seem to be a difference. And I guess we'll see if that gets confirmed in other studies, because now I think that did get people to want to study that. But it is interesting that it did become positive, at least in terms of the progression-free data later, or the event-free data later. So we'll see what happens with that. And obviously I think we're all excited to see KEYNOTE-522. I hope we'll see it at ESMO, is my guess, next, right? And so far, what is anybody using pre-op checkpoint inhibitor yet in their patients? Given, I mean, in the US, at least, probably nowhere else in the world is it approved, but are you giving it anyway? I have seen some people coming in with transfer of care for second opinions have been getting it. Does anybody want to comment on that?
I haven't given it yet. Yeah, I haven't. I've had a couple of patients kind of request for it, but I haven't been able to get it approved through insurance. And so I haven't given it, but I have seen, patients come from other places who have been successful getting it, adjuvantly and then adjuvantly for 1 year as part of standard of care.
Yeah, I would say I'm not giving it outside of a clinical trial. I will also say the one patient who begged me to give her a checkpoint inhibitor was able to get it somehow from compassionate care from Merck. And she ultimately got one dose of Pembro and had a red cell aplasia and required about 20 packed, units of packed red cells, beyond steroids, required, additional immunosuppression. And I know that that's a very rare side effect, but the point of the story is that if and when these drugs are approved, we still have to think about the risk-benefit ratio.
That is true, and PD-L1 status doesn't seem to be a very good biomarker in these early stage triple-negative breast cancer patients. So yeah, we still need to kind of understand who will benefit because of these rare but unpredictable serious long-term toxicities.
Yeah, I think we all are starting to see stories like that. So hopefully as these data become available and/or mature, they show really tremendous benefits that make it worth it for managing the short and long-term serious toxicities. All right, there was another abstract that I'm just looking at right now, thinking about, and there was a pharmacokinetic analysis in CSF and plasma from the TBCRC, looking at the efficacy of the combination and safety and efficacy of the combination of tucatinib, trastuzumab, and CAPE for the treatment of leptomeningeal disease. Leptomeningeal disease in the HER2 positive patients obviously is a pretty important problem. Kristina, I don't know if you want to comment on how often you're seeing these patients as a radiation oncologist these days, and how you think about these patients with your medical oncology colleagues or brain mets in general.
So we're seeing them a lot less since HER2 climb, especially in some of these patients who've had, prior, whether whole brain radiation or stereotactic radiation, then developed subsequent progression. Just because now we finally have a systemic agent that's able to kind of delay repeat radiation and some of the morbidity associated with that. I'm very rarely seeing some of these leptomeningeal patients. Unfortunately, it becomes an issue also with their overall performance status and limited life expectancy. But obviously in the HER2 positive space now with more systemic agents, this becomes a very important patient population. I'm not familiar with the details of that particular abstract.
The punchline of the abstract was that the tucatinib gets in the CSF.
Which we expected, I guess.
Good news.
So good to know.
And that's what we were hoping for. And we know from HER2 climb, which of course you just alluded to. Do you want to comment on the results of HER2 climb around this issue?
So for HER2 climb, basically, looking at patients with, I forget the exact study population patient, was it all metastatic patients? And then they looked at the subset who had CNS progression, and they could have had varying flavors of, prior CNS control in terms of radiation. So a mixture of whole brain versus stereotactic and even repeat. And essentially there was just this great survival benefit across populations where we saw that tucatinib was basically, improving the CNS control, which for a long time we didn't really have. So that was really exciting. It's often tough clinically with these patients. We treat them with one course of radiation, whether it's stereotactic. We try to avoid whole brain as much as possible, just given the fatigue and the side effects. And then frequently, it becomes also an issue of how many sites is it, reasonable to offer stereotactic radiation to? What do you do when these patients progress? So I think having an agent that has good CNS penetration is able to even potentially delay leptomeningeal disease is really exciting.
Olabisi, do you want to comment on, how you're managing your HER2 positive patients in the metastatic setting, particularly when they are at risk for and/or, so not just first line. We talked about THP as kind of many of our go-to, unless the patient's saying no thank you and wants dose reduction or not to take IV therapies, which you can understand. Do you want to speak to second line and beyond and how you're, especially in the metastatic to brain setting?
So for those patients with brain metastases, I am preferring the HER2 climb regimen. For patients who do not have brain metastases, I'm still using a fair amount of TDM1 in the second line. There is a question which comes up very frequently. So patients who don't have brain metastases or who have very few brain metastases that are kind of slowly progressing on TDM1 or Enhertu, when do you pull the trigger to switch them to the HER2 climb regimen, particularly if their systemic disease is under excellent control with their current line of therapy? For those patients, I generally do not switch them right away, rightly or wrongly. But if they continue to progress and the local therapy colleagues think there's limited options, then I switch them, or if they're becoming symptomatic. But if they have just a very limited progression, small volume disease, and they're still doing well, I tend to keep them on the current therapy, rightly or wrongly. But obviously, if the intracranial disease is presenting as a problem, then I prefer the HER2 climb regimen.
Yeah, it brings up an interesting, good problem to have. We have a lot of agents. Kevin, how are you thinking about these patients when you see them, with progressive disease and thinking about the sequencing of the HER2 agents? And I'm going to bring up a particularly, I find challenging a little bit around, where are you incorporating drugs like neratinib in that armamentarium? I will tell you that one patient that I talked about, she eventually, she's been with me for 10 years with a metastatic disease, and she's ridden the wave of multiple studies. So early on, she was on a study of trastuzumab and lapatinib, and actually had a beautiful response to that. And then later on, she was on a study where she got neratinib and had a beautiful response to that. I don't remember what she was on. Oh, she might have been on with CAPE. I think it might have been the NALA trial. And now do I give her tucatinib? When she's had that in the past, so how do we incorporate all these things now? It's an embarrassment of riches, although we haven't fixed everything.
Yeah. I mean, I think it goes back to kind of what one of the earlier points is, just practice patterns change over time, and increasingly it feels like they're changing quicker, which is a good thing. I think that, to me, tucatinib is the TKI of choice. For a patient who's not previously received a TKI, that's the one that I would go to. There are some data that were published in Breast Cancer Research and Treatment from the MD Anderson group that looked at kind of the response to, it just looked at sequencing and looked at, for instance, lapatinib after neratinib, and they did see some clinical activity. I think if a patient has CNS metastasis, it's reasonable to try another TKI. There are some data with antibody drug conjugates, including trastuzumab deruxtecan, that were reported at ESMO Breast, which showed for patients who'd received some radiation that, maybe there's some CNS activity. Just this continued question of the payload getting into there. And, of course, topoisomerase inhibitors can have some nice activity in the CNS. So I think, we'll see in larger data sets what those look like. But, to answer your question, I would feel okay with sequencing, even though there's not specific data about tucatinib post other TKIs.
Well, what's interesting, and I thought it was brilliant and really fantastic to include in the HER2 climb study, the patients who had progression of their brain metastases. And they kind of won in that, because, just with the study design, maybe knowing that their drug did go through the blood-brain barrier, or at least hoping for that, because I think that's where we're all kind of reaching for that. But as you alluded to, Kevin, I don't think we know that, for example, trastuzumab deruxtecan doesn't get through, especially in the setting of disease that's there.
Right.
Yeah. And I know they're looking at that aggressively, I'm sure, because it's good to have more agents that work. Other comments on that? And Kristina, do you want to comment on, when you are doing and patient that does need radiation these days, how you're approaching it, and some of the newer data, even if it wasn't at ASCO, around how many lesions is okay or too many for stereotactic radiosurgery, and when do we need to go to whole brain? I feel like in our practice, patients hardly ever get whole brain anymore, thank goodness, because if they're, especially with HER2 positive disease, sometimes I think the whole brain long-term is harder on them than the cancer, unfortunately.
Absolutely. I mean, there were the data on hippocampal sparing whole brain radiation that showed some improvement in cognitive effects. But I think in an era with more precise surveillance in terms of just, high resolution MRIs that we can get more frequently, just better technology in terms of being able to treat multiple isocenters with several different sites of disease concurrently. I mean, we're seeing, 5, 6, 10 lesions that can be safely treated, respecting the size and volume of the disease, as well as the patient's, performance status, that allows to really save whole brain really as a salvage for patients who've had multiple recurrences.
Bisi, any comments on that?
No, I agree with everything Kristina said. Yeah, I think whole brain radiation is not very common anymore, and what I see the radiation oncologists doing, they just keep going, as long as patients don't have, diffuse, very large burden of disease. And patients, again, with HER2 positive breast cancer, they're living much longer than they were 5, 10 years ago. So even with brain metastases, we have many patients living many years with brain metastases.
And I'm wondering if, I tend not to go to the really early drug development posters and presentations just because it's not where I focus my research. But I'm wondering if there were any new exciting therapeutics that were presented at ASCO this year that we think might be coming to the breast cancer arena sooner rather than later. I don't know if you want to comment on that, Kevin or Terry.
Yeah, I'm happy to mention a few things. I mean, I think one, there are the oral SERDs. So there were some updates for some of the oral SERDs that are in development. Also, like other categories like SARMs were discussed, selective androgen receptor modulators. So, I think that, the way that, Terry had mentioned that we had a number of aromatase inhibitors, we may be in the situation where we have a number of SERDs, oral SERDs that are approved, and they may have differential side effects and differential activity. And these large randomized studies, we are awaiting the results for, and some are just recently starting in terms of accrual. The other drugs, just to be mindful of, I think the HER2 space is really continuing to change, right? So we saw that results from the Ambrx HER2 antibody drug conjugate, and that waterfall plot curve looks really good. And then the associated toxicities with that drug include like ocular toxicity and potentially pneumonitis. And then we also heard by press release, like right after ASCO, just the results of the TULIP study, which is SED985, trastuzumab duocarmazine. And that was a positive study, which again, that has this potential ocular toxicity and shortness of breath. So I think that there are more HER2 drugs that are coming down the pike.
Which is great, right? We keep our patients tolerating everything and available so that when we get those home runs, or at least the base hits, we'll take if we can't get the home runs with the therapeutics. I want to switch gears again, and now we are in our last 10 minutes, so thank you for your patience with us, and talk a little bit more about some of the data that were presented by Dawn Hirschman from SWOG, where she presented long-term results from the acupuncture cooperative group trial that she ran through SWOG. And did anybody get a chance to think about that? And does anybody want to I can tell us the results if you want to hear that, or do you want to comment, Kevin? You're a SWOG guy. You're Dawn's person, or you used to be. You left, but
yes, no, Dawn. I'm familiar with her work in this study. So ultimately they looked at, and these data had been published, just looking at doing acupuncture for patients in terms of AI-associated arthralgias. And I believe the schedule for the first 6 weeks was twice a week, and then it went to weekly. And the updated data showed that, with longer follow-up, that there was still, I think it was a year later, I could be misspeaking, but it was sometime later, they still showed a improvement in those patients who received acupuncture up front, even as opposed to getting it maybe in the delayed setting. So, to me, the continued question that I have from these data is this is clearly a positive study. I still have a hard time getting insurance to cover acupuncture, and I'm not so sure what else will be required for that to happen, especially given that we see some durability of benefit.
Yeah, they went out to 52, although the differences seem like they're coming together, but they went out to 52 weeks, but certainly by week 24, there were stark differences between the two groups long after the actual intervention, which was only 12 weeks, was done. So even if you could provide someone with temporary, even if you had to get a booster once a year or every 6 months of your acupuncture, and then or take your break from your AI for 3 months, and then you get some relief from your musculoskeletal complaints, wouldn't that be nice? So it is a real problem that our insurances don't routinely cover things like this. So everybody listening should, when you're speaking with your Congress people and lobbying for things, covering supportive care so that people can stay on treatments that are life-saving. It's not just about feeling better, it's about living better and longer. That's my pitch for things like adherence and supportive care medications, because if the patients don't take them, they don't get the benefits, right? In our last few minutes, any other comments from the ASCO 2021? Kristina, when you reflect on your experience watching ASCO this year, what do you think was kind of the most exciting to you as a radiation oncologist, especially?
I think just there's a lot of exciting work being done, obviously, in the metastatic space. I think, you know, the CDK4/6 inhibitors, as well as even the Olympia data, just looking at kind of PARP inhibitors. You know, one thing I was reflecting on is, you know, this role of understanding kind of, you know, the BRCA positive patients and looking at these germline positive mutations. You know, a barrier we sometimes have in our community setting is kind of both insurance coverage of a lot of the genetic testing, and then just also genetic counselors, and kind of the availability of going through that process to even survey our patients to identify this potential patient population that now has all these novel therapeutics that can really improve their outcomes. So, you know, I'm hopeful that, you know, with these exciting data that show that we're able to really improve the outcome for this patient population, it'll make it more readily accessible for us to get insurance coverage for, you know, some of the genetic tests, and then even just maybe there'll be more genetic counselors, so we even have more patients, more people to refer our patients to kind of go through the process.
Kristina, you bring up a phenomenal point there, which is, should we be testing all of our patients for germline predisposition to breast cancer, in particular, the ones that we might be able to act on, certainly BRCA1, BRCA2, and maybe PALB2, just given the kind of data available. That there's going to be mission creep. Let's not kid ourselves with that one. And hopefully it'll get paid for. The numbers are fairly small, so hopefully we'll be able to get away with it with insurance, or you'll pitch for it and not have to. You can't do another randomized trial of those patients in the adjuvant setting. What are people's thoughts on that? Should we test everybody when they come into Terry? Are you testing all your patients when they come in for their surgery? Are you saying, should I do a double, or do I just do a lumpectomy? What's your process there?
I mean, for younger patients or patients that have some sort of reason to be tested, you know, like according to the guidelines, we do test. But I sometimes, obviously, that figures in the decision of what you do. A lot of the times, patients make this decision for mastectomies or bilateral mastectomies based on purely their age and their family history, which sometimes, and also I don't particularly use it for older patients, you know, like over the age of 65, whether somebody has genetic predisposition or not, their rate of additional cancers in the opposite breast or in the same breast, it's almost about the same as the, you know, age-related same population. So, but I think that we should test almost everybody, I think, at this point, because, you know, the tests are getting cheaper, the time is getting faster to receive the results. And I think it becomes essentially a biomarker. So why not have the biomarker to make a decision? Every so often you may run into somebody that has a BRCA mutation that maybe came from the father's side, and there's not a lot of members in the family. She's a little older. And then why should you deprive that patient potentially from a very effective treatment as we have now? So I think we're coming to that point. And, Mary Claire King made that pitch years ago from San Antonio. And I think we're coming to the point that as the prices get cheaper, the panels are available, you get the results very quickly. It's a biomarker. It's not like the old days of $3,000 or $4,000 to get a genetic testing, So I'm hoping that we'll get to the point that everybody will be tested.
Yeah, I think we're all leaning towards that, or at least more likely to say, hey, are you interested, and not kind of hold thresholds the way we used to in the same way, of course, trying to follow the guidelines. But if someone's particularly interested, I definitely send them, even if they don't make guidelines. Obviously in the metastatic setting, now that we do have approved agents there, those patients, I do try and get them all tested if they'd be a candidate for a PARP inhibitor, if there's any whiff of a potential for genetic predisposition. I don't know if others have comments on that.
I think it's such a good question, just also about who's doing the testing, right? It's something that we've been talking. Are we doing point of care testing? It's our volume of doing genetic testing is not just increasing in breast, but increasing in other solid tumor types as well. And at least here, and there was like this at Columbia too, our genetic counselors are really overwhelmed. So it feels like our practice patterns will catch up to these data, at least in our group.
Yeah, a lot of people are changing the pattern where they're showing a video and then you get counseled if you're positive. That's the kind of new movement. BC, I'll let you make the final comments on what did you find most exciting? What do you, it could be what we talked about or anything else. What's most compelling and maybe practice changing for you?
I think the Olympia study is the most compelling. It's very exciting to see the PARP inhibitors being adding to, the overall clinical improvements in patients with BRCA mutations. And I think you raise a very good point about, if we're going to be testing all breast cancer patients for these mutations, I think very soon we will be. And that may be a way to close the current racial gap, because we know that, African Americans who are eligible for NCCN testing right now are not getting tested as much as their white counterparts for a variety of reasons. So maybe testing all breast cancer patients is a way to potentially close this racial gap. But I think, even outside of the racial disparities, I think we're going to be testing most, if not all, our breast cancer patients very soon.
BC, I think your comments were, of course, so right on, and especially to talk about ASCO 2021, when we had the beautiful opening ceremony and the whole theme that Lori Pierce led to try and make sure that we take care of every patient everywhere and not just select patients and really mitigate the disparities. And I think we should all bring that home to our practices every day, right? Not just right after ASCO. So with that, we'll end because we are right at the middle of the hour and we're supposed to end now. And I'd really like to thank all of our audience for listening and to each of you for being here with us tonight and spending this time reflecting on what you saw and what you're doing in your own practices and what we all hope for the future with regard to improving the care of patients with breast cancer. Thank you and have a great night.